Hi, Matt.
Hi, now I can hear you. I was worried.
Hi, Pablo.
Imad. Hi, Pablo.
Hey, Vladimir.
Vladimir,
Hey, Vladimir.
Eva.
See you.
Looking forward to see you.
It has been long time.
Long time.
I will let Huda pass by and say,
Hi,
Huda. Hi.
Hi, how are you? Nice to see you guys. Hi, Pablo. How are
Hello,
you?
Huda. Good to see you.
Vladimir, how are you, Vladimir? Eva,
Fine.
Fine.
Thank you. Thank
Everything
you.
only a small community now.
Yeah.
sorry to interrupt you, Vladimir, please. I might need to leave any moment if they call me
Okay.
to the hospital. Our number one is in the hospital. So we
Sure.
have been meeting 100 times today.
I read that. I read that in a newspaper.
Bye-bye. Enjoy it.
It is the same here.
Bye-bye, Eva. Bye-bye, Huda.
The same here. It's rather busy, but boring because it's you are at home all the time. Or hospital, home.
I just sneaked out to have my coffee with Huda and then she'll meet you guys. Yeah, I have to go back at 4 o'clock unless they call earlier.
Yeah, me too. I've got to be 4 o'clock.
Yeah,
I am already in the hospital. Ready.
You are in a hospital.
Yeah, I have a clinic at 4 p.m. also.
Yeah. We have the same. Great to see you
But-
guys.
But your
Great to
prime
see you.
minister is not in the hospital. The king is in the hospital, Imad.
Oh, don't mention the word, please. Number one. We used to say number one or Elvis. Elvis is in the hospital, and it's a gallbladder issue. Last night, there were 12 arrived on a private jet from US, 4 surgeon, 2 endoscopic, just name it, infectious disease. And every day we meet 4 times, and the decision is made, I think, the cholecystectomy, but they are pending the family decision. So they said there will be another meeting today. I don't know when, but anyhow, I am with you guys unless I'm sneaked out. My role as in the neurosurgeon is not very big, but
No,
still they want to
that
see
was
me.
very neurosurgical.
I cannot do a transcranial stone removal.
No, you can try supra infra.
Really, really infra. Huh?
Yeah,
This is
send him here.
beyond
I
the
shall do
level,
it.
yeah. Infradiaphragmatic, yeah.
Yeah, guys, I can tell you that my parents, 99 and 97, just survived the whole this stupid COVID, and
Oh,
they had no
yeah, wonderful.
symptoms whatsoever. But they were locked for a
Wonderful, that's
month in an infectious disease department. It was like a jail.
So they were positive, Vladimir.
They were positive. They got it in this retired people home, and they were hospitalized in a infectious disease department. And for a month, they were in one room, you know, really like a jail. Now they are negative, so they went back to the retired people home, and they are 99 and
that's great.
97.
Wow,
Can you
that's in
imagine that?
your genes.
Yeah.
God bless them.
That was pure luck.
Very happy to hear that.
All the disease is
Yeah,
not that bad.
my grandmother got it with 93 and she couldn't survive to it. So it was, no, it was 2 months ago.
2 months ago.
She was fighting for 4 weeks, but finally she passed away. But in Spain, we have had a lot of retired people with severe problems.
Yeah. Now it's
But
getting
that's your
better. Now,
genes.
yeah.
So
As long we are alone still
Almost
on the
time.
screen,
Sandra is
Vladimir,
there
thanks
also.
for the response on that email. But I have to be a little bit tough with our friend in Toronto. He hasn't responded to any emails for 5 times, and then come with the suggestion to advise to change the program and make some plans, which I could not tolerate it, and I have to be very obvious with him. And
Fully
if you
agree with
remember,
you, Imad. Fully agree with you. You got my mail as a response.
I don't like people, they stay in hibernating the whole night, winter, and all of a sudden they wake up, remember there is something called committee, and they start making improvision rather than contribution. And the other things, when we put the IPA second lecture to duplicate the brainstem, the poor guy, he sent them to me that he could not access his thalamic tumor material, and he wants to present it. And last time he did not present, and he sent his presentation early. That's why I said, let's hear 2 people. And the other things he was asking, why you put somebody endoscopy for the colloid and 1 microsurgery, because there are 2 techniques, and we'd like to hear both of them. How is the results? So, but anyhow, first I was planning not to respond, but this has been a repeated issue with him, and I have to stop him on that level. He should focus to be a member. He is not leading this society or committee, and he should yield on contribution actively. You see, that's what I meant.
I had the same experience with him several times, Imad. Several times it was exactly the same. Big idea, let's do it. And that was the end of it.
That's true.
So I fully agree with you, fully.
Thank you. Hi, Sayed. Sayed
Hello.
Ali, you are from Dr. Salman?
Yes, sir.
Group?
Should I start the presentation? I think sir is busy in the operation. Hello. Dr. Pablo?
Yes.
Can you hear me?
Yes, perfectly. We are ready.
Should I start it? I think sir is a little busy.
Whenever, I don't know if Salman is planning to open or if he's here or not, but we have Professor Kanan, Professor Benes, and Professor De Pujari here, who are the moderators for the session. So whenever you decide, we can start.
I'm ready, so if you are okay with it, we can start.
Okay.
Okay, Pablo, I think you just go ahead and we will make the initiation, the moderated while the presentation is going on. You agree, Vladimir and Dr.
Certainly.
All right.
Certainly.
Go ahead, Pablo.
Chandra.
So,
Hi,
Doctor,
Chandra. I don't see Chandra on the images.
I saw him before, but he's muted.
He's muted.
Yes. Okay.
Right now, he's unmuted.
I can speak now.
you just have learned.
Good afternoon, everyone.
Good
And
afternoon.
I think if Salman is busy, we can get started and he'll join later.
So Dr. Maruf is going to start with an anatomical presentation discussing the most relevant aspects about the insula lobe and its relationship to the sylvian fissure and the operculum. And later on, if you agree, we could have some cases for discussion. Maruf, all yours.
Hello, everyone. I will be presenting on the anatomy of sylvian fissure and insular region. So the sylvian fissure is the central and central circle, the most important landmarks on the lateral surface of the brain. It is a complex feature which carries the middle cerebral artery and its branches inside of it. And it is also important because it provides the surgical gateway connecting the cerebral surface to the anterior part of the basal surface and cranial base. As you can see in little MRI of the brain, the sylvian fissure is running, and it is also marked with a red mark over there showing that this is the sylvian fissure. So it is from this this part of the axial slice from that insect. It is the now this MRI is showing the coronal cut of the brain, showing the sylvian fissure over here, which is covered by the opercle of the frontal and the above and the temporal region below. Now the sylvian fissure is divided into two parts: a superficial part, which can be seen over here in the diagram, and a deep part, which is buried beneath the inferior surface of the frontal lobe. The deep part is also known as the sylvian cistern, which is, as I already mentioned, hidden below the basal surface. There is a dilatation in the sylvian fissure that is known as the anterior sylvian point. It is important in the surgery, as well as the apex of the insula lies directly beneath this point. And it also divides the sylvian fissure into its main anterior rami and the posterior rami. The anterior rami that can be the horizontal and the ascending rami. The same picture again is showing the anterior cellular point over here, which is dividing it into the anterior rami, the horizontal ascending, and the large posterior rami.
Dr. Maruf, sorry to interrupt you. Can you
Yes.
speak louder and come near to the microphone?
Okay. Can you hear it, me? Is it okay now? Dr. Kanan? What happened? I can't hear you. Yes.
Yeah, go ahead. Yeah,
Okay.
it's fine. Thank you.
So this is the part of being the brain from the anterior side, where we have retracted the temporal lobe below it. So you can see that there's a sylvian fissure and some parts of the insula can also be seen in here. This is lamina insula, which we will discuss later. It's the part where the frontal lobe is connected to the temporal lobe. As I previously discussed, the superficial part of the signal feature is the stem and three rami. The three rami are the horizontal, ascending, and the posterior rami. The stem, which begins medially at the anterior crinoid process and extends laterally along the sphenoid ridge between the junction of the frontal and temporal lobes to the pterion. The stem divides into anterior horizontal, as anterior ascending, and the posterior rami. The posterior ramus, which is the longest, represents the posterior continuation of the fissure, separating the frontal and parietal lobe above to the temporal below. So above will be the frontal and parietal lobe, and below will be a temporal lobe. It runs posteriorly and sharply ends in the inferior parietal lobule. So this is the same picture showing the anterior ramus, horizontal and ascending part, and the posterior ramus where it is ending sharply in the inferior parietal lobule. The deep part of the sigmoid fissure hidden below the surface is referred to as the sigmoid cistern, which is further divided into the sphenoidal and opercular insular compartment. So this diagram shows the inferior surface of the brain in which the temporal pole has been removed, showing the temporal stem and the sphenoidal compartment of the deep part of the Sylvian fissure. So here we can see anterior perforated substance over here, the lamina insula on the lateral part, temporal stem, and the cerebral peduncles inferiorly. This is the picture showing the view of the brain which we see from inferior side. The temporal pole has been removed from this region, and the frontal operculus has been seen over here. The signal fissure can be seen over here, and the temporal stem can be seen because the temporal lobe has been moved and the anterior perforated substance. So the roof of the sphenoidal compartment is formed by the posterior part of the orbital surface of the frontal lobe and the anterior perforated substance, as you can see over here. This is the superior. This slide shows the superior part of the temporal lobe, which we are seeing from the above. As you can see, this is this side from the floor of the by the anterior part. The floor is formed by the anterior part of the plana polare, which we are talking about the sphenoidal compartment, and area free of the gyri. As you can see, there are no gyri over this surface, and a shallow area which accommodates the middle cerebral artery course. The anterior segment of the uncus, the side of the amygdala, is located at the medial part of the floor. The lamina insulae, the prominence overlying the uncinate a prominent fiber bundle connecting the frontal and temporal lobe, is located at the lateral edge of the sphenoidal compartment. We cannot see the lamina insulae over here because the temporal pole is occupying over it. As I've seen, it's shown in the previous diagram. This is the lamina insulae, in which if we remove the temporal lobe, we can easily realize the lamina insulae. The opercular insular compartment is formed by the two narrow flaps, opercular and insular. The opercular flap is situated where the Sylvian surface of the frontal lobe, parietal lobe above, faces the Sylvian surface of the temporal lobe below. So this is the area where the opercular insular compartment is formed. So this is the enlarged same picture which has been enlarged, showing the opercular insular compartment formed by the opercular of the frontal and temporal lobe above, and frontal parietal lobe above and temporal lobe below. The picture showing the if we view the brain from the front side, the temporal pole has been removed, showing the frontal opercular and the opercular insular compartment over here. Now we'll talk about the some anatomy of the insula. The insula has a triangular shape with its apex directed anterior and inferiorly toward the lemon insula. The lemon is located at the junction of the sphenoidal and opercular insular compartment signal fissure. The insula is encircled and separated from the frontal, parietal, and temporal opercular by shallow limiting sulcus. I'll be showing the diagram of each of these in the next couple of slides. The limiting sulcus, although roughly triangular in shape, conform to the shape is commonly referred to as the circular sulcus because it encircles the insula. So after reflecting the frontal opercular and temporal opercular, we can visualize the insula, in which different gyres of insula can be seen. The one known as the short gyres over here and the long gyres over here. So these both are separated by a sulcus, central sulcus. Over here we can see a circular sulcus which covers the whole of the insula and separated from the frontal, parietal, and temporal opercular. As you can see, the frontal opercular and the short gyres of the insula, and here is part of the circular sulcus which separates both of these structures. This is the diagram in which the frontal lobe has been removed and showing the insular region. The sulci and gyri of the insula are directed superiorly and posteriorly in a radial manner from the apex at the lamina. So this is the apex, insular apex, and from which the gyres of the insula are distributed. The deepest sulcus, the center sulcus of the insula, is a relatively constant sulcus. So this part is the center sulcus. This divides the insula into anterior and posterior regions. The insula cover the lateral face of the central core of the hemispheric course, formed by the extreme capsule, which is over here, the colostrum over here, external capsule, lentiform nucleus, internal capsule, and the thalamus. The caudate is over here. So all of these are covered by the insula. This is a diagram showing the temporal lobe has been removed from the and optic radiation is preserved, showing the insula in which the long gyri can be visualized easily, the short gyri in the central sulcus, and circular sulcus as well, which separates the insula from the operculars. This is another diagram schematic showing the insula in which the operculars has been reflected, the frontal and the temporal opercular, showing the central sulcus dividing the short gyres from the long gyres. In this diagram, we can easily see the 5 short gyres: anterior, middle, posterior, accessories and transfers, and 2 long gyres: anterior long gyri and posterior long gyres. This whole constitutes the insula region. This diagram shows the vascular supply of the insular region supplied by mostly by the M2 segment of the middle cerebral artery. This short artery that can be seen in the denoted by the arrows supplies the insular region. Thank you for it.
To ask, was it expected to cover not only the brain matrix, but the vessels? He showed the vessels, but that was the plan, or you will expedite on these vessels, because this is the most important part in management of insular lesions and to care of these vessels.
I was not going to explain the vessel, the overview of it. Mainly the gyre part was I was going to do.
Well, I do have in math, as I will have some pictures we can discuss if you want. I have some images, we can discuss the vessels also.
The veins as well, probably.
Yeah.
And of course, it's not only after I said, it's veins as well.
Good.
So you said the insula cover these structures directly, or there is a white matter in between? Because you mentioned about the internal capsule.
No, the insula, the inside structure or the outside structures? So are you saying about this one? Is this the diagram you're saying, Dr. Kanan?
Sorry, the insula, yeah, you have to tell because it said it cover indirectly, isn't it?
Yes, sir. Yes, sir. It's covered indirectly, the structure beneath it.
The thalamus and the other stuff.
Other
Okay.
stuff. Yes.
What is the relation of the internal capsule regarding the insula? Is it more on the posterior aspect or on the anterior aspect?
More
It's
on the
an
posterior
important
side.
decision to make when you go and dig. You are in the island. When you are in the island, you might get lost if you don't specify the anatomy where you are going to expect the internal capsule, usually in the posterior part of it.
Yes, yes.
Thank
More on the posterior side.
Thank you.
Thank you, sir.
Matt, sorry. Matt, may I show one picture about that?
Oh, yeah, sure.
We reinforce that concept you use. I don't know if you can see my screen.
Yes, we can.
Yes, we
Yes,
see it.
That's a perfect point, and it's very important to understand this subcortical area. 160 degrees perspective. So this is the axial cut showing what you showed in a coronal. Your coronal cut, Maruf, was placed more or less at this level on the anterior aspect. So this is why once you go inside the insula, for a glioma, for instance, you have the putamen and the globus pallidus in between you and the internal capsule, the anterior limb and genu of the internal capsule. But if you go posteriorly, we do have the posterior limb, which is just subcortical, because the thalamus is medial to it. So that's the main difference. This is why Professor Kanan was asking you, and you perfectly said that it's most posteriorly related to the insular surface, because this is the anterior limb, sorry.
And of course, the posterior limb is the important one for all the corticospinal tract.
Yeah. So that's what we usually see, the anterior limb, which is protected by the putamen, but the posterior limb is very, very superficial. So I have some cases which were difficult because of that, because the posterior extension of this glioma is very, very close to this area. So this is why generally this is the area we leave for the end of the surgery, and we start working with subcortical stimulation here, trying to find this motor response, because this is the posterior limb. That's why this is so important to understand. I don't know if that was...
That's very clear. You show it very nicely. I have one more question to the fellow who presented. What is the anatomical relationship between the insula and the Broca area, the speech area?
The Broca area, the Broca is represented by the pars triangularis and the parts of the pars opercularis.
Not here.
You are far from your microphone.
Okay.
It's not very clear
you-
what you say. Speak
hear me
slowly
now?
and louder.
Can you hear me now? Hello.
Very low voice.
I think there's a connection problem.
No, we hear you, but it's not loud enough. Just come to the microphone, bring the microphone up.
I have in my hand microphone.
Okay, that's good. Okay, if you hold it next to your mouth.
It is formed by the pars triangularis and the pars orbitalis, the part of the frontal opercularis, the Broca area. So it's related to the insula.
So more on the anterior part.
Can I show that?
Sure, yeah, please go ahead.
So this is the left side, and we have been splitting here the Sylvian fissure. So we are exposing this triangular shaped structure, which is the insula. So here we can see nicely this pars triangularis, posterior aspect, and the anterior aspect of pars opercularis. This is the so-called Broca's area. It's mostly related with the superior and anterior aspect of the insula, close to the insular apex, and in very, very close relationship with the so-called anterior Sylvian point.
Pablo, some reading, they say that the insula, they divided in different quadrant or 4 quadrants, something like this, anterior, inferior, anterior, superior. How we can project it on the cadaver?
This is the so-called Berger-Sanai classification.
Sanai, yeah.
This is the one you are mentioning. And let me see if I do have something to show about that. I have a nice slide about that, but I didn't prepare it.
This is the group from
San Francisco, UCSF.
Yeah.
Berger. They have a nice classification about insular tumors divided in 4 quadrants, which are mainly, let me show you in a, I don't have that slide. I would like to show, but here even we can identify that they divide it into 4 quadrants. So they analyze the MRI of the gliomas growing in the insula, deciding in which area of them it's a big volume of tumors, so they can predict how much they will take and at which risk. And by far the most dangerous area, let's say, is this posterior superior quadrant, in which we saw that we are very close to the internal capsule. So, but there is a nice paper about that. From Berger and Sanai. It's a beautiful one. It's very to the what we call the fronto-orbital operculum. The superior and posterior is mainly related to the frontoparietal operculi, and the inferior quadrants are mainly related to the temporal operculum. The posterior one related with the Wernicke's, which is also very important to identify. This is transverse gyrus of Heschel, and the anterior inferior one is related to the temporal pole. Mainly with T1, in contact with T1 and the so-called planum polare, which is hidden right there. I don't know if I have a picture. I can show you later on some pictures of that.
For the fellow, does he know, do you know what is the meaning of opercular? Why are they called opercular?
It is a Latin word which means cover. That is why it is called
cover.
opercular.
Exactly. This is the gown or the cover. Some dictionaries, they say this is the river bank as well, because the Sylvian fissure is the mainstream of the carotid artery conducted by the middle cerebral artery. And the 2 river banks on both sides, these are the opercular, temporal and frontal, or the cover, because you know they cover the Sylvian fissure, these structures. Very good. Sorry, Pablo, go ahead.
No, sorry, we can continue. I have some cases to discuss if you want, so you can let me know. Should I show them?
Yeah, go ahead.
Okay. So, first of all, Maruf, congratulations. You did a nice job, and maybe there was a small gap on the artery, so let's try to discuss them properly also. So I was preparing a few cases, but let me do a brief introduction because it's important to know who are the ones who opened the groundwork for us, and it was Penfield, the one who started doing awake surgeries on the insula, and he was reporting very, very interesting functional results about that. This is a free paper, you can Google it, and I really recommend to read this paper, especially considering that it was written in 1955. So you can imagine how interesting it is. But it has been recently, and this is also a obviously proof which is the goal right now, nowadays, especially in highly eloquent areas like the insula, is to diminish morbidity and to extend the resection. So that's our goal, to take as much tumor as we can and to preserve the neurological function. So we could think that this is difficult because obviously it's in a highly eloquent area, and something very useful is to classify tumors. This is not their classification, this is a much more classic one, but in my mind, it makes more sense in order to plan your approach, which is the idea. Obviously, the classification from Berger and because you can predict how much tumor you can resect and at which risk, but this one is better for practical purposes to decide which is the approach. So this is a purely insular tumor, this is a fronto-insular tumor, this is a temporo-insular tumor, and this is a completely operculo-insular tumor invading the insula and both operculi. And I will try to show you different cases and how these findings can modify our strategy. And unfortunately, as always, there are some different points of view which are fantastic, but we should take advantage of absolutely everything. And there is a kind of discussion if it's better to go Transylvian, it's better to go transopercular. And the Transylvian group, it's obviously, we are trying to preserve the anatomy of the operculi, and the idea is to stay within the tumor. So we split the Sylvian fissure, we go inside the tumor, and then we try to preserve the normal anatomy. On the other hand, the transopercular group, we are removing some, let's say, non-functional tissue in order to reach what we call the functional resection, which means to go as far away as trying to find the function. So we preserve the function and removal of our tumor. Different philosophies, but I think there is no battle. We have to take advantage of both of them and to study properly our single case, not only radiology, but also how the patient is doing, how we can be, and then we decide which is going to be the best approach in our hands. Even some cases I have done a combined approach. So with all these concepts, and neuroanatomy, as always, for me is the key in order to decide the planning, surgical planning, but also important to study the anatomy in the MRI, functional MRI, DTI tractography, to see the relationship of our tumor with the tracts, because the insula, as we will see, it's covered and surrounded by very, very eloquent white matter fiber tracts. And finally, intraoperative technology is always very, very important. So we must take advantage of absolutely all these tools, and I will show you some cases. Surgery, we can do cortical, subcortical stimulation. We can use the ultrasound, it's very helpful in order to see how posterior our tumor is running. Neuronavigation can be also interesting, and the CUSA and some stimulation tools. And finally, the microscopes, endoscopes, PHLA, ICG, everything, we can take advantage of that. So let's go to some cases.
May I ask you one question, as long as you have this just shown the slide? The biovercular approach, do they prefer to go through the temporal, or sometimes they have to go the frontal opercular? Of course, so, on the dominant, you have to go through the temporal, you cannot go through the frontal. Yeah. But on non-dominant, is there a preference, or sometimes you both? Because I saw the arrow, the red on both sides.
Yes, generally, well, I just draw this for practical purposes, but generally it depends of the technique, surgical technique, and the experience of the surgeon. But generally, personally, through the operculum, which is invaded. So if it's a fronto-insular tumor, I try to identify the operculum which is invaded by the tumor, and I start my resection there. If it's a fronto-temporo-insular tumor, you can use both windows. And in case you have a purely insular tumor, but you don't feel confident to split the fissure because of some technical things, or because the MCA branches are in front of you, what you can do is you can do a wake surgery and to check all the operculi and to decide which is the non-eloquent one, so you can close that one. So that's the general point of that. Thank you, Matt. But I will try to show you how I do it. And this is the first case. This is a British lady. She was having fun in Alicante, and then she had some seizures. And this is a question for our colleagues. Maybe our fellow can help us. Watching the image, where do you think this tumor is located? Naruf, are you there? Have a look at the image. Which lobe?
It's in the insular region, and insular region mostly in the
and
right
you can now be more specific. Yeah, in the posterior part. So
posterior part of the right upper column, I think so.
Very good, very good. So it's an posteriorly located insular tumor, so mainly located in this region. And do you know the name of this gyrus, which is in very close relationship with it?
This Heschel gyrus.
Yes, so you can see Heschel gyrus, how it's coming from this point. Do you know the name of this point?
Posterior Sylvian point.
Insular point. Sylvian point is super. Insular point is yes, very good. So this transverse gyrus of Heschel is running anterolaterally and finally joining T1. So at that level, we estimated, understanding the anatomy, you can see transverse gyrus of Heschel here in the MRI. So that's gonna be key, because this is gonna help us. And the transverse gyrus of Heschel generally is kissing the post-central or subcentral area. So this is our entry point in case we want to do a Transylvian approach. So this is dominant hemisphere, and the operculi which are surrounding this area are quite eloquent. From anterior to posterior, we do have the precentral, post-central, supramarginal regions, all of them highly eloquent. And inferiorly, we do have the Wernicke's area at the level of the supramarginal and transverse gyrus of Heschel. So this tumor is completely surrounded by highly eloquent operculi. So this is why, in this case, in my mind, it is issue when we decide to go Transylvian is to study the veins. Obviously, to study them on cadavers, to know where is the superficial Sylvian vein, which sometimes can be crazy. Like in this case, we can have 1, 2, 3, or even 4 superficial Sylvian veins, and to try to identify where are the main draining veins going to, if they are going to the frontal or temporal operculi. So generally, we can decide that intraoperatively. So this is the exposure of this case. So here we can use the ultrasound to get a good orientation about the relative location of this tumor, which was mainly located here. So here we have pars opercularis. This is a Sylvian point, anterior Sylvian point. So that's pars triangularis, opercularis, precentral, postcentral. So this is the point in which the transverse gyrus of Heschel, as we said before, is joining T1. So this could be a very nice window to go through. As you can see, we don't have too many veins in that area. So that should be the ideal entry point. So this is what we are doing. We start opening the fissure, and in this case, we don't need to go too anterior. So we are releasing some CSF, and just with this small opening and being very patient, we can split this posterior aspect of the fissure. And here we 5-ALA was not useful in this case, unfortunately, but we were sure because we use the ultrasound to localize that region. So that's the tumor you can see. And then it's a matter of debulking and identifying the superior and the inferior circular sulci. You can see we left a remnant here because we started having some motor response. In the most posterior part, you can see how the internal capsule is very close to this area. So that's one case about a Transylvian approach. And we did a Transylvian in this case because the operculi surrounding the lesion were very eloquent. This is a different case. And Maruf, I need you again, or someone, anyone can help me to where this tumor is located. 29 years old guy who presented with scissors. Completely controlled. Where is this tumor located?
I think it's mainly involving the most of the ocular region.
Mainly
the frontal and parietal apicula mostly.
Well, it's very important to see all the images, and I just was able to show you these ones, but believe me, maybe here it wants to go too, but the operculi are mainly displaced, not invaded in this case. You can see that how the insula is perfectly drawn. So we have the short gyri completely insufflated here in this axial cut, and the long gyri behind. The lumen insula is right here, and all the operculi are kindly pushed, but the tumor is not leaving those limits. And what do we have medially here? What is this, Maru? You can always go.
The extreme and external capsule over here.
Yes, and just underlying these capsules, the gray matter here is
the gray matter, the lentiform nucleus.
Yeah, the putamen. You can always go to the healthy hemisphere. You can see the putamen here and how it's compressed here. So it's a big tumor, but very kind because it's not invading adjacent areas. And can you see these black dots?
Yes, these are the vessels.
These are the vessels. Do you think they are inside the tumor or they are subarachnoid?
They are in the subarachnoid region.
So if you see this image, it can be scary, but you expect this to be a low-grade glioma in the insula. So these vessels are not inside the tumor. They are in the depth of the sulci of the insula. So generally, this tumor can be approached. It's the right side, so we can do a transopercular approach to the pars orbitalis and pars triangularis. But look at what the tumor has done. It has splitted the sylvian fissure for us. So it's almost open here. You remember this point? The name of this point?
Point.
Right here, anterior sylvian point. So this is a, let's say, weak, empty area, and this tumor has taken advantage of that. So what we will do, you can see in the intraop image how this anterior sylvian point right here is widely open, and this white tissue, this is the tumor already. So this is why in this case, I also believe that opening the fissure will help us. We just cut the arachnoid and the tumor is there. We can do a wide opening of the sylvian fissure, that's the carotid in the vallecula, and then we start the debulking inside the gyri. But in between the gyri, we will see these vessels, which are the branches of the MCA. So in this case, we can coagulate these small perforators of the MCA branches, and there is a nice perforator. You can see, we are coagulating all these small perforators and cutting them. Going deep in the inferior aspect, we opened by accident the temporal horn. So we reached the head of the hippocampus. So it means that we finish, and then we are moving superiorly, but always working in between the vessels. This was probably the central artery of the insula, which is very important to preserve. You can see the small perforators we are cutting, and then we work on both sides of this artery. And finally, we move to the most posterior aspect, which Imad told us this is the dangerous area. So we trust a lot on subcortical stimulation. And finally, we try to look for the lenticular striate. So this is the post-op. We couldn't see all these vessels because they were hidden in the depth of the sulci, not inside the tumor. And now these MCA branches, we are using nimodipine, intraop nimodipine, to prevent vasospasm. So that's the post-op.
Do you use
and you can see
as well, Pablo?
I would like, but it's forbidden for many years in my place. They don't buy it anymore. This is why I'm using nimodipine, but it's working quite nicely also.
Yeah, wonderful. We are still using the papaverine. We are privileged to have it.
I could, but I never had the chance because when I arrived to this hospital, it was already not. We were not allowed to acquire it. Yeah.
And I think the French group, they use it as well. The DAFO group, they use it. Now, one thing about the vessels, you mentioned you coagulate the very tiny vessels, but just for the education, not the great perforators from the thalamus striata. They are essential for the internal capsule as well.
Yeah,
so just
that's a very important point, Imad. Thank you. Yes, and indeed, the first, but nowadays I do prefer to go more and then to attack the vessels through the subpial aspect. So if you are going subpial, you will be protected from those vessels. Maybe they will bleed, yes, with much better because you are not using the bipolar.
Yeah.
In case you have to coagulate these small perforators, it's much better to do it anterior of the tumor because posteriorly, I will show a picture in which we are showing some long perforators even reaching, as you said, the internal capsule. And here we have them. This is a paper from Professor Touré and Professor Yasahil, in which they are proving that the small perforators in the anterior area are stacking at the level of the claustrum. They are not going deep, but these long perforators, mainly in the posterior part, they are reaching the corona radiata. So if we coagulate one of these, which are generally located in the posterior and superior aspect, we can have a nice surgery, but with one of these small perforators, we can have an infarct. And same thing happens, as you said, with the lenticular striate. If we go too deep, especially in the most anterior-inferior part at the level of the lumen insula, we can damage some of these lenticular striates, which are coming from the internal carotid artery and M1, crossing the anterior perforated substance, crossing the putamen, and reaching, as you can see, the internal capsule. This is the internal capsule, so these perforators are reaching that. And I have a case to show you that I damaged one of these lenticular striates, and I will show you what happened in the post-op MRI. So next case. This is very similar to the one we showed before, so we will not stack too much, but the nice thing about this one is this Maruf. There is an artery in this sulcus, so the tumor is in both sides. Which sulcus we will have in the middle of the insula? Maruf? This sulcus. What is the name of this?
Can you show it again?
This
central sulcus. This is the central sulcus of the insula.
In this case, central sulcus of is growing on both sides. What kind of tumor are you expecting to have here? Very homogeneous enhancement. He was 56 years old with headache. That's it, headache. What it could be?
Could be a meningioma.
This is an intrinsic tumor. Forget meningioma. I am asking you because I made a mistake. Don't be shy.
I don't know about.
Okay, so I will show you. It was finally a lymphoma, which are rare, but they can appear in the insula. And I was not expecting that because the routine workup was negative. So we needed a biopsy, and generally in this area I prefer to do open a biopsy because we are having many vessels on that. See this rim enhancement here? This is the external capsule. You see here, this is the external capsule just lateral to the putamen. So in this case, as we said, and deep to the external capsule, we have the putamen. So that's the tumor right here. This line here, this is the external capsule, is the putamen. So this is the opening, again, of the fissure. Quite nice to us. posteriorly, and then we enter through a safe area, relatively safe area. So that's the tumor there. So we debulk it kindly, and we are getting, you see, the pia. We are moving now the pia. Instead of coagulating those vessels, we are pushing them. And once we go deep, look at what we see here. This gray substance, that was the lateral aspect of the putamen. And I said that I did a mistake because in a lymphoma, there is no need to resect the tumor. We didn't resect it completely, an open biopsy. And as everything was going well, we decided to resect as much as we could. But let me show you again. This is the lateral aspect of the putamen. And this white matter here is the external capsule. You can see the same windows in the specimen. This is the external capsule, and lateral, medial to it, we have the putamen, this gray substance. Let me skip this one. We have discussed this one before, and we can go to the next one because these examples will illustrate something we were discussing before. 39-year-old man who came with seizures controlled with one anti-epileptic drug. And Maruf, this is a different one. Could you let us know where do you think this tumor is located? And with the axial cut, you have many information.
Involved main upper pillar in this case. As,
so this is the insular compartment. As you said, two operculi are invaded.
Yes, invaded.
What is this area of the brain?
This is the frontal opercular.
Yep, nicely. And this one?
Temporal opercular.
So it's a tumor invading both operculi, and it has some enhancement. So we expect maybe to have at least a grade 3 in this case. Finally, it was an oligodendroglioma. So this is the case, in my mind, as we were discussing before, to do a transopercular approach. Why? Because the tumor is already invading these areas here. So in case we are in the right hemisphere, we can skip awake surgery, and I prefer to skip it when we are dealing with. And we can just go through the sick operculi. So this is what we did. We will work through two windows. First of all, through the temporal or frontal operculi, and once we finish removing both operculi, we can connect these two cavities behind or below this spiral area of the insula. We check with intra-op monitoring where the pre-central and post-central areas are, and then we use this N20 wave inversion, so we know the central sulcus is in between number 3 and 4, and then we place our grid to check directly, continuously, how the corticospinal tract is working. We release some CSF. This is a maneuver very helpful always to release some CSF. And I'm opening a little bit the fissure just to have a good orientation where the tumor was located. You see this color? That's the glioma, oligodendroglioma in this case. Then we go deeper, and this is the temporal horn of the ancus. And now we go up, try to go subpially to the insula. And this is what we are doing. Through the temporal operculi, we are reaching the insula. That's the insula. And we are pushing the vessels upwards and working behind them from the temporal operculi. Whenever we are in a dark area, in a hidden area, then we move to the frontal operculum. And we do the same maneuver. We go deep, and then we go down behind the vessels in the insula. So we try to connect both cavities. This is what I believe a good transopercular approach, because we are removing T1 where the tumor was growing, and also the pars orbitalis and partially triangularis, and we are connecting these resections transtemporal, transfrontal behind the vessels in the insula. And this is what we can have. So we started going transtemporal, then we went transfrontal, and we connect both resections behind, going through these two areas in the most anterior aspect of the insula. And always we have this, in low-grade gliomas, we have this remnant of the tumor very close to the corticospinal tract. Frontotemporal, fronto transtemporal, transopercular, and subarachnoid. This is a different one, which is mainly invading the whole temporal lobe. So in this one, we had to do a temporal lobectomy and also partially invading the fronto-orbitary gyri. So this is a tumor which is mainly growing through what we call the uncinate fascicle. This uncinate fascicle is part of the limbic, all the limbic system connecting these areas, fronto-orbital and temporal pole. So probably this tumor took advantage of this pathway to invade both areas and staying also in the insula. You can see how the uncus is very, very highly invaded by this tumor. So in this case, same concept, we release CSF and we do a transopercular approach through the temporal lobe. This is the insula. That's the insula through the temporal lobectomy. This is the temporal horn. After removing the uncus, we have a nice view of P1, P2, and the third nerve. And this is the insula completely exposed. We have covered the insula. It's covered by two arachnoid layers, the temporal and the insular one. And then now we do our transfrontal resection. At some point, I think I have shown this case many times because it's very nice. This is both atus in the midline because the gyrus rectus was also invaded. And now we are removing the insula through a frontal window. But at some point, we started having some problems in the contralateral motor response. And it is said that vasospasm does not occur with transopercular approaches, but let me show you that I had a problem. Look at this black dot. This is one of the MCA branches. So there was some vasospasm there, probably due to the manipulation and the blood clots. But if you touch that artery, you can see how the flow wants to go inside. So again, we use nimodipine and we are releasing this vasospasm. So even in transopercular approaches, we can have this complication. So it's very important to be aware of all this. So different case again, invading the uncus, temporal pole, invading also the pars orbitalis and partially pars triangularis, and invading the most anterior aspect of the insula. This is an ugly tumor, but finally it's behaving quite nicely because we did this case in 2014. It was a grade 3 oligoastrocytoma, and he's responding very nicely to chemo and radiotherapy. But in this case, what I want to show you is something different. So you saw how we were opening in some of these cases which are invading the uncus. We are going through the temporal pole in order to take the head of the hippocampus and the amygdala. And it's important to be aware that the optic radiations are just the roof of these two structures. So we are using cortical stimulation, subcortical stimulation, and we are not using awake surgery. I personally don't use awake surgery for most of these insular gliomas. So it's important to have these optic radiations always in your mind. And also very important to identify where the lenticular striate arteries are related to the tumor. You can see the lenticular striate arteries in this case, which are just medial to the posterior part of this lesion. So opening the dura again, right side, releasing some CSF. This maneuver is very helpful, as I told you, to release CSF and relax the pressure. And in this case, we wanted to expose, hello Salman, we wanted to expose T1 from above using 5-ALA. We can see how it's enhancing, and through T1, we are reaching the inferior peninsular sulcus. And if we go deep, we will expose the uncus, which is right here, and the optic radiations are above. So this is P1, P2, and this is the midbrain. That's the moment to stop temporal resection. And now we do the same in the pars orbitalis and triangularis. Same thing. And in this case, we opened the fronto-orbital gyrus and we saw the carotid with the lenticular striate arteries. This is the M1. So those are the lenticular striates, which means the anterior perforated substance is just there. I didn't want to go so deep. Posterior aspect of the uncus, third nerve, tentorial incisura. So the tumor was invaded the uncus. This is why we wanted to remove it. Everything was doing well. And he's doing well, fortunately. But look at what happened here. This is 4 years later, but there is still an ischemia. at the level of the genu, let's say, of the internal capsule. So this is because one of these lenticular striates, probably I damaged unintentionally one of them. And we were lucky. There was no neurological problem with this problem, but even something such small like this can cause us a very, very important neurological problem. And this is the last one. This is a 31 years old lady. And again, Maruf, I will need you to help me identifying some anatomy. First of all, it's insula, obviously, but yes. What part of the insula? Is more anterior or more posterior?
More at ear, involving the frontal apiculus and some part of the temporal apiculus.
What is the name of this point?
The anterior sylvian point. Anterior
sylvian point. So you can see how the tumor is drawing perfectly the anatomy of the insula. What is this in a normal insula? This.
The apex.
This is the apex of the insula. So you see the normal insula, how it's respecting the shape of it. And what are these gyri?
These are mostly long gyri and above.
Long gyri, perfectly, which might be partially invaded. So again, this is going to be the difficult area because here, what structure we do have?
It's a posterior part of the internal capsule.
That's it. So this is the key to respect this area. And what is this?
This is the thalamus.
Again?
Thalamus.
Thalamus is here, quite posterior and medial to the internal capsule. We are anterior.
Basal ganglia. Caudate nucleus. Sorry.
Caudate. This is the head of the caudate. Okay? So you always have to study the anatomy of the tumor. So here we have the normal insula of the same patient and how it's drawing perfectly the anatomy on that area. And this is the intraoperative landmarks that we should use. Sorry. These are the intraoperative landmarks that we will have. And in this case, let me show you, I think I have a coronal cut. You saw in the case before that the vessels were inside the sulci, but in this case, we were very lucky because both the main trunks of the MCA were in the inferior peninsular sulcus, so right here. So we didn't have to deal with many of those vessels. So again, we make use of our intraoperative tools. This is the sylvian fissure, so we are marking the relationship of the tumor with the surface and then the sylvian fissure. And again, this tumor is just there. It has been splitting the fissure for us, partially. That's a tumor, you see? Already there. You can see how the tumor wants to go out. So the fissure is split for us. Then we cover our operculi. Try to stay inside the tumor. We will find vessels, branches of the MCA, and we must respect them. And what I'm using nowadays, once they are dissected, I place a small layer of spongostan covered with nimodipine, and I just continue the resection. Always try to go subpial, and these are the main trunks of the MCA, as you can see in the inferior peninsular sulcus. So now we are going to the dangerous, we are going to the most delicate area, which is in the posterior aspect. We are moving posteriorly, and this is the point where the subcortical stimulation is going to be very helpful because we are getting close to the internal capsule, as Maruf perfectly identified in the pre-op MRI. And here we found response with 4 milliamps. We check it with the CUSA because we stimulate with the tip of the CUSA. So we went a little bit superiorly, and again, we found a response there, 3 to 4 milliamps. So even if you see some tissue, or at least if I see some tissue, tumor tissue, I don't take it. I just prefer to leave a small part there and try to preserve the function. And you can see that not very nicely here, but there is a remnant in this posterior aspect. This is where the stimulation was giving us relationship of the insula together with the posterior part. And here, once we have removed the tumor, the nice thing about that is that you can perfectly identify that the posterior part of the insula was not invaded, as we were discussing perioperatively. So I think that was all. I hope I have not bored you. I like to show this picture. This is one of my patients, which are our best teachers. I really believe on that because we are learning your attention.
Well, wonderful, Pablo, as usual. You have demonstrated nice cases with correlation to anatomy and highlight the importance of vessels, area of language, and the internal capsule. These are the essentials. And on the non-dominant, of course, the language area is very important. We have to remember the functionality of the triangle of Ryle. This is the old name of the Sylvian, the Insula, actually, was the discoverer of this island that is supplied by the middle cerebral artery. This is the main river to this area for blood supply. With its branches, the thalamus striata. This is the important point you mentioned, that the vessel should be respected, whether this is on the venous side or arterial side. And like sitting on the shore and along the river in your chalet, you have to respect the walls between the neighbors. These are the vessels, so you can work through different channels to communicate this tumor without damaging the vessels. Well, we appreciate the work and we appreciate the resident's presentation. It was a very good presentation and complemented with the vessel anatomy. Well, thank you very much. I leave the podium for Sulaiman. Hi, Sulaiman. Let's see, Salman.
Hi, Imad. How are you? And Pablo, I'm sorry I was stuck in a case, so I apologize. And I understand I've seen the last bits of the cases, so I apologize I wasn't there earlier. Chandra, your thoughts?
I think the anatomy was well described, and the importance of vessel has been further elucidated by the cases which Pablo showed. And he showed cases in all the 4 areas which we were earlier talking about. So I think it's a very good learning experience. I just wanted to know, we haven't been using subcortical stimulation, how reliable it is, and have you got your own parameters or are there standard parameters?
Well, for motor, I think there is no better way to know when to stop. We are using the classic parameters 3 to 5 milliamps, but what our neurophysiologist is doing, once we start, once we finish the neurotomy and we identify the precentral gyrus with the N20 wave inversion,
Right.
she's doing a kind of test. So as the patient is not awake, he's sleeping, but without muscle relaxant. What she's doing is she's starting at, let's say, 0.5 milliamps, and she's increasingly the amplitude, so we can check more or less which is the ideal parameter for that, for identifying the motor function.
So in every case, if you are
that we
looking
do
at, sorry, in every case, if you are looking at phase reversal to map the motor area, that means you need to do a larger craniotomy in every case.
Well,
Do you use awake craniotomy at all, at least on the dominant side?
I don't used to do it. I have only done it once, and it was very uncomfortable experience for the patient and for us also.
We've been lucky to do a reasonable job with awake craniotomies, and we rely on that. But I would like to know experience of Imad and Vlad.
For the dominant, we'd like to do the awake resection. Now, we keep mildly sedated, but at the time of the resection, then we'll let them raise up and we'll do the awake resection. So at least the phase for the taking off the pain from the craniotomy and the opening the dura, this phase is well controlled. But when we reach the phase, we need to have evaluation of speech and semantic and all these things. This is important on the dominant hemisphere to have it, especially if it's reaching the opercular and you are working frontal opercular and you are working on these gyri. May I have one question message as well. I'm sure you mentioned it in your discussion. We should not depend on the neuronavigation when we are in, because with the shift, everything is not acceptable. And I think ultrasounds is the name of the game, as you showed, if you need to see if there is a residual. You mentioned as well on the blue dye and the fluorescein, you use it.
Yes.
And this is another option. It's not available everywhere, but I think the ultrasound is something handy. And what kind of probe do you use?
It's an 8 millimeters. One we have the 8 millimeters one, and we have bigger ones. But for these purposes, even a big one is okay, because we use it to know before opening the fissure how anterior or posterior the tumor is growing. And for remnants, you can use even a big probe. Oh. So it's a regular. It's not something very specific. The ultrasound we are using, it's quite cheap, quite affordable. In the hospital, we don't have too much money, but this one we could get it easily. And about the question from Chandra, and the thing is, generally with our policy, if we have a tumor, operculo-insular tumor, obviously we do a transopercular approach. And generally, these tumors, if they are invading opercular regions, we expect not to have function there. We always do functional MRI. And I have been very lucky. I didn't find any case in the dominant hemisphere yet. I didn't find it yet. Hope it remains like this, in which the tumor was invading the speech area. I didn't find it yet. So we try to go quite anterior with the transopercular approach. And otherwise, if we have a peri-insular tumor, we always try to do a transylvian if it's reasonable. So this is why we don't use awake surgery, but for another kind of gliomas, we use it. We use it a lot.
Pablo, two other questions. One on the question of the preoperative MRI. Do you use the DTI at all? Because the SLF, the UNCINET, and sometimes even the ILF marking can be quite useful when you are deciding on are you going to take the operculum or not. What is your experience?
Well, I personally really like tractography a lot. Maybe I'm biased because I have been working so much time in the lab with white matter dissections that even if you look at the MRI, normal MRI, and you can imagine where the tracts are, for me to have them clearly tracked, it's very helpful, because this is helping me mainly to decide through which operculum we can go, if we can go more anterior, more posterior, more basal, or more superior. So I use it, I could say always with this kind of lesions. I do tractography. Yeah.
The second question is, Dr. Kannan partly answered that question, but I am a little skeptical. Are you using nimodipine topically? Are you saying that you use nimodipine on the vessels, or do you give it intravenous?
I use it topic.
Okay. We have never used it topically. I mean, papaverine works well, but we use intravenous nimodipine in addition. So I don't know. Vlad does a lot of vascular surgery, so maybe he can tell us. Do you use topical nimodipine, Vlad, at all?
What we use is papaverine. We are lucky to have it, and we use it topically. I several times I have used nimodipine and I haven't seen any response on the vessels. But getting the word, Pablo, I believe you have excellently showed that the posterior upper part of the tumor is always the most difficult one. We have intra-op MR for more than 12 years by now. And almost always in all the gliomas, the posterior part is a remnant which we leave behind. Even if we see it on the intra-op MR and you would be tempted to return back and to continue your resection, usually the evoked potentials don't allow you. We use something, our electrophysiologists have, it's like 1 milliampere is a 1 millimeter. And we tend to quit at 4 millimeters distance from the lesion, because there already may be the vessels, and you clearly have shown that the posterior limb may be supplied by the perforators coming out from the distal MCA, and that's important.
Yes, yeah, fully agree. And I recommend, for that purpose, I recommend the paper from today, which is called Arteries of the Insula, where he's proving how these posteriorly located perforators are reaching the corona radiata. Yeah.
Right, right. So there you could, and there you leave a piece behind, almost always.
Yeah, always. I didn't estimate in how many, but I could say that 90–95% of our insular gliomas, you can always see that triangular shape.
The triangular shape remnant. Exactly, exactly. We all have that.
I try not to have it, but I always have it.
The same. Unhappy triangle.
Thank you, Vlad. Thank you.
Pablo?
Salman?
So, yeah, how much of nimodipine would you use, and what exactly, is there a particular strength that you're using?
Well, this is a question I must really prepare very well, because everyone is asking that. And the thing is that our anesthesiologist, who is fantastic, is taking care of that. I would say she's using 60 milligrams dissolved in 100 cc's. And this is what we use. And we don't use it injected. What we mainly use some cottonoids on them. And I am very happy to say that I can prove that it worked. Vladimir said that it never worked, but I have one case in which I can prove it worked, and you saw it. How
that's the one you have shown.
Yeah.
Do you use some mechanical means of releasing the vasospasm, Pablo?
That's right. Pablo. You massage the vessel and you can.
Yes. Massage. Let's leave it there.
I have an experience that these mechanical vasospasms, which you cause during surgery, are most frequent in young ladies. You know, whenever I'm having a young lady and I need to manipulate the vessels, I use papavin, because I'm always afraid of vasospasm in these young females. Chandra, probably you have the same experience.
47-year-old lady, that one I showed you.
It was a 17-year-old, well, probably the Spaniards live longer.
47 years old lady.
47, yeah, that's it. That's the upper limit.
There is a question, Pablo, the preoperative functional MRI. Is it helpful to avoid awake craniotomy on the left side?
Well, I also use it. And in the cases in which we are doing awake surgeries, we are always checking both results, and it's fitting quite nicely, but not always. So what I have seen is that, functional MRI is showing sometimes too many spots to be understood. So those ones who are highlighted in the functional MRI, almost always we find some response. But there are some places in which we had this dot in the functional MRI, this activity dot, and we couldn't find response intraoperatively. So I really prefer awake for speech areas, but I use it also.
Pablo, another question. In our hands, awake craniotomy is strictly reserved for speech areas. But there are people who are using this for Rolandic region area, awake craniotomy. Do you do this or not?
No. And I have been in some centers learning where they use it. And I personally, in our place, I don't see any advantage for that, because you can really trust on cortical and subcortical stimulation for motor areas with the patient sleeping properly. So the response is the same, and the risk of having seizures is much less, and the risk of having an anxious patient and an anxious surgeon is much less when we are in the motor area. I don't use it. I use it in the SP areas.
What do you do when you are having an intra-op seizure?
So the classic thing is to use, we have always some ice in the water, so we use very cold water, and we irrigate, we take everything out, we even place the microscope out, the lights out, in order to avoid heat. So we try to coat the brain, and we wait. That's it. Usually they release fast.
Thank you.
Pablo, there's another question that what is the most frequent language sequelae in cases of damage to the insula?
So in my experience, it's mainly due to the damage. I have two patients, very, very sad cases, in which probably I damaged the IFOF. It was a subcortical damage, not a cortical. If you damage the cortex, you will have some aphasia and some anomia, something quite, let's say, rudimentary. But if you damage the IFOF in the most anterior aspect, at the level of the lumen insula, we can have severe speech deficit. They start with mutism and they can only say yes or no for a few days or weeks. And then they have to learn, and there are some words that they cannot use properly. And I have one patient who is having severe problems even 2 years after surgery, so I don't expect he will recover, mainly due to the subcortical damage. Quite deep in the IFOF. Once you are removing an insular glioma, IFOF remains quite deep, but I'm sure that was a problem in that patient I have.
Pablo, you said you were using functional images. What do you do with multilingual patients? Do you just investigate the mother tongue or all?
No, we have many, as you know, here, and we try to identify both languages. In fact, the last one we did, he was Spanish, speaking properly English, and he was married with a Dutch lady. So that was a tough one, but we try to explain them that the intra-op test is going to be longer, and we try to at least to track the main two languages. At least we didn't check Dutch because well, they
managed
could
to get
communicate
rid of Dutch language, so no
But you
communication
just
would
investigate coughing. You do not need to investigate any language. It's Dutch. I had a patient with 6 languages once, and that was a disaster. You know, we did functional, and all the acquired languages were small in the region. The mother tongue is a huge area which it covers. The acquired languages were much smaller, and it was like you do some skiing, like a slalom between the areas. It was a mid-temporal tumor at the time, a kid.
Okay, brilliant. Can we have a look at multiple choice questions? Any questions from the audience? If you have any questions, just raise your hands and we'll unmute you. Pablo, you want to take this, please?
These are Maruf's questions.
Okay, Maruf, are you there?
Yes, sir. So question 1 is, which artery is carried by Sylvian fissure? And answer is middle cerebral artery. So most of them are correct. Someone is also right. Question 2, on which surface lateral fissure is present? And the answer is lateral surface.
Okay.
So most of them are also correct in there. And question 3 is, what are the different parts of Sylvian fissure? Different parts of Sylvian fissure that I've already discussed is superficial and deep. So A is the correct answer. Which again, most of them are correct. Question 4, the Lyman insula connects which structures? And the correct answer is the frontal and temporal lobe. And which are the structure lying beneath the insula and the indirect as well. So all of the above is the correct answer.
Okay, brilliant. Do you have any more questions? Let's have a look. Imad, do you have, sorry, this is Imadullah. I'm sorry.
Thank you.
So there is a question, do we have to check all languages in multilingual? That's from Al Hussein. This is for Imad Kanan.
What do you say?
Do you have to check all languages in a multilingual?
I'll take the mother tongue and the next prominent because I know Dutch is not going to happen to me.
Okay, and there's a question that is the posterior Sylvian point used to localize the superior posterior aspect of insula? Pablo?
That's the main landmark for that, yes. That's key to identify it in the peri-op MRI.
Okay, brilliant. Imadullah, can you please show us what we have lined up for next week? Actually, on Saturday, we have an IFNE WFNS endoscopy committee. Do you have that? No? Yes?
No, sir. I'm using other laptop. That's why I don't have them.
Okay, sure. So we have that on Saturday at 5 o'clock, the usual time for IFNE WFNS endoscopy committee. Yeah. And we have 3 speakers in that. And then on Monday, we have Danny Pavidello and Azmi who are going to be talking about principles and tricks of posterior fossa endonasal surgery, and along with that, Azmi is going to be talking about anterior skull-based lesions. Okay, and in a week's time, we'll be coming back with, I think, speech area. Is that correct, Pablo? You are unmuted. You need to unmute yourself, Pablo. Yes.
Oh, I did it. Sorry. I think we were planning to talk about limbic areas.
Okay, we do the limbic first. Okay, fair enough. So brilliant. So I know everybody who's coming in, let's just prepare yourself for it. It's good to read up before in advance, and it's good fun. And thank you, Pablo. It was, as always, great. And thank you, everybody. And Imad Karan, obviously, you as a moderator have to wrap it up. Thank you.
Thank you.
Thank you, Imad. Thank you, Salman.
Well, thanks for everybody for the presentation, for Dr. Maruf and Pablo for the excellent presentation, and for the contribution of Vladimir and Dr. De Vigera, and of course, I'd like to thank Salman for keeping us active and attentive to this very successful webinar. Congratulations.
Thank you, everybody. Bye-bye. Bye-bye, Vlad, Chandra, everybody.
Bye.